So I was invited to speak on ARV and TB drug-drug interactions. And I knew it was a case-based workshop, but to be honest, we don't have that many cases in the Netherlands on HIV and TB co-infection. So I have a case, but it's a very short one. I'm not asking you to vote. That gives me more time to review also the most recent scientific literature on this particular topic. So I'm happy with the time that is available for that. So these are my disclosures. I have a very short case description, but then I will focus really on the new data that have emerged over the last couple of years. And that's mainly on the rifampin dolutegravir drug-drug interaction. Now, I think that's a very important one because we all know that rifampin is the cornerstone of TB treatment, so it will be frequently prescribed by you for your patients with TB. And we also know dolutegravir is really the first-line agent, also hopefully here in the region for adult patients. And there's a direct interaction between these two. I will explain it to you. I will also focus a little bit on rifampin as TB prevention. We've heard that this morning, how important that is. But it also causes some DDIs, and then I will finish with some conclusions. So this is the very brief case presentation. It's a true patient from our clinic a few years ago, a female patient, 54 years old, and she presents with a TB HIV co-infection. Well, it was a fully sensitive TB, so we could give the standard 4-drug regimen, including rifampin, and the standard first-line treatment for HIV in our institute is separate tablets of tenofovir FTC plus dolutegravir 50 milligrams BID, so that's an increased dose of dolutegravir. Normal dose is 50 milligrams once a day, but you have to increase the dose when you combine it with rifampin. I will show that in the next slide. And in our institute, because we have limited experience with that combination, we always do therapeutic drug monitoring on dolutegravir in these patients. And we measure the concentration, the trough concentration of dolutegravir, which was 0.27. And I will give you some interpretation later on during my presentation. So the information that you have to adjust the dose of dolutegravir from once daily to twice daily when you combine it with rifampin comes from this healthy volunteer study, a phase 1 study. That's a standard way of studying drug-drug interactions, normally during clinical development of a drug. So that also happens with dolutegravir. Because already it was anticipated that patients on dolutegravir could develop TB, and then you have to give rifampin. So we needed to know how to combine that, these drugs in these patients, and that's the reason during clinical development of the drug, this phase 1 study was conducted. I will show you the design of that study. Quite nicely, I must say, is that they started with 50 milligram once a day of dolutegravir alone. So this is in healthy subjects, so no HIV patients. They only received 50 milligrams dolutegravir once a day for 1 week, and then they did a PK sampling during 24 hours, the full dose interval. Then, because it was expected, based on the metabolism of dolutegravir, which is metabolized by UGT, so glucuronidation is the metabolism of dolutegravir, and it was already known that rifampin can induce that enzyme, so there will be more rapid elimination of dolutegravir. That was the expectation. So they already thought that maybe we have to increase the dose to compensate for that interaction. So then they did another week of doubling the dose of dolutegravir, already without rifampin. And then after 2 weeks, they repeated the PK sampling, so you could make a comparison of twice daily versus once daily dolutegravir. And then at week 3, they started with rifampin. So it's only rifampin, it's not TB treatment in total, because these were healthy subjects. They gave that for 2 weeks, because then you have your maximal induction of your UTG and also other enzymes. And then after 4 weeks, they completed with the last PK sampling. So you had 3 PK samplings, which you can make very nice comparison between these 3. And these are the results. I will go through it with you. So the first week, the first treatment was the 50 milligrams once daily dolutegravir, which is here with the squares. Yeah, it's a square. And that's the line that you can see here. I hope you can see it, yes. So the 24-hour curve leading to a trough concentration of dolutegravir, which is the most important PK parameter for efficacy, around 1. And you will see that value coming back at several times during my presentation when I present some of the more studies that have been completed. So that's the normal pharmacokinetic curve of dolutegravir leading to a trough concentration around 1. So then if you increase the dose to twice daily dolutegravir, you get this curve, which is of course much higher, even more than 2 times higher, now with a trough concentration of 4. And you give it twice a day, so you have a 12-hour dose interval and then another second dose during the day. And then finally, the last curve is with the combination of rifampin. And then you see exactly happening that this twice daily curve, the 12-hour curve, is reduced to here. And now you have again the 12-hour curve. And you come back exactly to the same point, the trough concentration around 1. Because of the effect of rifampin, which reduces the concentration of dolutegravir, but because you increase the dose of dolutegravir, well, just very lucky you end up exactly at the same concentration, which means very clearly that if you have to combine rifampin with dolutegravir, you have to give it twice daily, and you come to exactly the same result. So this is, well, more or less, let's say, the ideal PK study with the ideal results as you would have had hoped when you started the study, and that's a very clear recommendation how to combine rifampin with dolutegravir, and that's also in the label of dolutegravir. However, when we were looking at these data, and also during the years after the drug became available in the market and sometimes being used in patients with TB, we ended up with a couple of, let's say, remaining research questions. So, although we had a very good, well-conducted phase 1 study with a very clear recommendation, you could still come up with a couple of questions, and I will discuss them with you, discuss these with you, and also present some of the data of studies that have looked into these questions. So, the first question is, okay, a phase 1 healthy volunteer study, that's not a patient study. So patients are not the same as healthy volunteers. Can you really translate one-to-one data from a healthy volunteer study to a patient study? So you would like to see some confirmation of this drug interaction in real patients. And another question is that, okay, the recommendation is clear, you have to go BID dosing. But at the same time, also many people realize that dolutegravir actually is a very effective drug with normally trough concentrations which are about 15 times higher than the IC90. So you are far on the concentration effect curve. So maybe that's not needed to be that far, and maybe you could stay with once daily dosing despite the interaction with rifampin. So it's good that with BID dosing you come back to once daily results, but maybe that's still too high. And also people realize that in TB treatment adherence is so important, and the BID dosing might be a problem for adherence, especially also if you have a directly observed therapy. You can do that, let's say, once on a day. And then the second dose, well, maybe not easy to have a directly observed intake of that, or maybe patients forget to take it at home. So if you have this increase of the dose, maybe you could also give 100 milligrams once a day instead of 50 milligrams twice a day. You have the same dose per day, but you give the whole dose in one time. Maybe that's also okay. Another question that has come up is that I hope that some of you have some experience also with higher doses of rifampin, which there are some data showing that it could be more effective, or you can shorten the treatment duration, or in certain severe cases of TB, for instance TB meningitis, where higher doses are given. Because the rifampin is an enzyme inducer, maybe higher doses of rifampin gives you more enzyme induction. So can you translate these data from the normal dose of rifampin with dolutegravir to also higher doses of rifampin? Gives you the same induction and is the same dose recommendation still valid? And then finally, of course, we always have to look at other populations. What about children? If you have a child with TB, HIV, can you apply the same dose modification? Yes or no? Well, I will go through some of the data that has been published over the last couple of years, trying to answer all of these questions. So the first question about the use of dolutegravir in patients versus healthy volunteers, and this is about the BID dosing that was recommended, comes from this study, and there are also other reports. But this is a study that looked at a cohort of patients at several sites in sub-Saharan Africa, and they made a very nice comparison of the use of dolutegravir in these patients, and they made a comparison with a similar group of patients also treated at the same sites, but then still with efavirenz. And they also had a data set available, historical data set, how patients were responding on efavirenz. And this is all with TB, HIV, and all with rifampin. And if you then look at the viral load results, that was about 80% in the efavirenz-based treatment, both historically and also at the same time. And you can see a difference, an increase, an improvement in viral load response, which is exactly the same as had been shown in the clinical studies without TB. So really dolutegravir also in the TB, HIV co-infected patient is doing a better job than efavirenz. And this is with the BID dosing. And one important question that was also part of that evaluation is that people were concerned that if you have, for instance, TLD, so tenofovir, lamivudine, and dolutegravir as a fixed combination, you need to have a separate 50 milligram tablet of dolutegravir in order to give that BID. And there's a lot of concern around the world that might not be available in programs, so that people cannot give the twice daily dolutegravir for that reason. However, in this survey, it turned out that 90% of these sites in sub-Saharan Africa did have access to separate tablets of dolutegravir for the 50 milligrams. And they were able, and they also did, give it twice a day in case of TB, HIV co-infection. So that's important real-life information. So then one of the other questions came up, if you don't want to give it twice a day for adherence issues, can you give it then the 100 milligram daily dose once a day? And this is a study that was conducted also in healthy volunteers, so this is not patients. And they did 4 different periods in the same subjects. Again, they started with the 50 milligram once a day. That's the normal dose for dolutegravir, as you can see. And then you have the trough concentration. I just told you it was 1, but it's depending on the units that you're using. So you have 1 milligram per liter, which is the same as, let's say, 1,000 nanograms per ml. So either you see people presenting 1 if they use the milligram per liter, or 1,000 if there's nanogram per ml, but it's the same concentration. So this is the normal concentration. If you give it as 100 milligram once a day, you double the trough concentration. So you get the 2,000 here. Then they started to give rifampin, added to the once daily 50 milligram. That actually was data that was not in the previous study, the phase 1 study. So that's interesting that now we also have the evidence really that rifampin is reducing the once daily 50 milligram concentration. And you have to make the comparison between this value and this value. So that's about a 90% reduction in the concentrations of dolutegravir. So a very strong interaction. That's the reason we are spending so much time on discussing this interaction. It's a very strong interaction. 90% reduction of your trough concentration of dolutegravir. And then if you increase the dose from 50 to 100 milligram once a day, okay, you see again the doubling almost of that trough concentration. But it's quite low. It's by far not the 1,000 that you would like to see and what was expected and also shown in the first phase 1 healthy volunteer study. So you can do this. It might have some benefit, but you don't really get the same exposure as with the 50 milligrams BID. And then a lot of discussion started with this paper and also with other papers is that, okay, these are the effects, but what are we aiming for? So what is the target for the dolutegravir concentration? Do we want to have it back at the normal level of 1,000? Or can we go lower? And how low can we go? And there are two important values that people are mentioning. There's an in vitro IC90 value, which is quite low, 64 nanograms per ml. And there's also some clinical data from 2 different studies that show you should be around 300 nanogram per ml, or 0.3 milligrams per liter, and that's an in vivo estimate. So these are 2 targets that people are referring to, and you can imagine that it really depends on which target you select, whether you think that some of these interventions could be recommended, yes or no. This is a small study from Italy when they looked at patients on either 50 milligrams once a day or 50 milligrams twice a day. And you see here the dolutegravir concentrations in the patients with rifampicin. This is a control group of patients without rifampicin. Again, you see this trough concentration around 1,000 and a very strong reduction, also with the 50 milligrams BID. So in this patient cohort, you don't come back to, let's say, the 1,000 with the BID regimen, but it's better than if you stay with the 50 milligram. Then you really go very low. A little bit confusing. The Italians use another target, so that's the 3rd target now, 100, but you never see that again, so I don't know why this was included in this picture. You better look at the 64 or the 300. So the Italians said, okay, once daily dolutegravir is not possible with rifampicin. You really have to give it twice a day. This is another study from Switzerland where they also looked at patient data. So they evaluated all their patients on dolutegravir in the Swiss cohort study. And they looked at the various regimens that people were using, including rifampicin. And they did some modeling work to see if you then change the dose of the dolutegravir, what is the result when you combine it with rifampicin. So here it starts again with the normal dose of 50 milligram. You already are now used to it. You get a trough concentration of around 1,000. If you give it twice a day with rifampicin, they also confirm that you don't come back to this 1,000, but you're still at around 400. So that's a 60% reduction still in the dolutegravir trough concentration, despite the increase in the dose to twice daily. Then they said, okay, if we're going to model, if you give it once a day, 100 milligram, then you have a very low concentration of 94, which is more than 9 times lower than in the standard dose. And they said, well, maybe you even have to give 100 milligram twice a day to really come close to the 1,000. So from this modeling exercise, they even say 50 milligrams BID is not enough. You have to go to 100 milligrams BID in patients. Well, that's quite a strong recommendation, I would say. But we have to realize that in their modeling study, they only had 9 patients in the POP-PK model with TB HIV co-infection. So it's quite a small study where they use that information to come up with these predictions. So that's something that really needs to be validated before we can really follow their advice. And there are some other data, clinical data, that are suggesting, well, more or less the opposite, that you don't have to go that high with your dolutegravir dose. This is an analysis of data from Botswana, where they looked at TB HIV co-infected patients. They had a control group of patients that did not use the dolutegravir. And if you focus on the viral load suppression rates, then they have in their cohort more than 90% response rate, which is what you would like to see in HIV treatment cohorts. They apparently had a group of patients in Botswana where they stayed with the 50 milligram once a day, despite the interaction with rifampin. But it gave the same result, 95% treatment response. They had a group of patients, more or less the same numbers, where they did increase the dose of dolutegravir, but you still get the same 95% response. So if you look at these data, and this is not pharmacokinetic data, but this is clinical data, viral load response, you would conclude that it's not necessary to increase the dose. So if you can still follow me, you have some data from the literature, PK studies, that say, well, maybe you have to increase the dose even to 100 milligrams BID, and then you have clinical data, clinical study, showing that maybe with a normal dose, 50 milligram once a day, despite the significant interaction, you still have good viral load results. So you could say this is conflicting data. Well, let me see whether I can explain it. It's all about targets. It's all about what you are aiming for. This is a recent paper from the South African group, again a modeling paper, where they looked at the various interventions. They looked at 3 different patient populations, so they also looked at the body weight of the patients. And that's, I think, an interesting aspect which I have not yet discussed with you, to not only look at one group of patients, but really look at subgroup or risk groups. And they looked at patients of 50 kilograms, 70 and 90 kilograms. I think for the Asian patient population, the 50 kilogram might be most representative. And they looked at it, well, if you have the 50 milligram once a day, just normal dose, you come around this value of 1 milligram per liter. If you then add the rifampin, you really have this strong reduction, and you go below this target of 0.3 milligrams per liter, but you are, with the large majority of patients, above this in vitro target of 64. So this could be the explanation for the good viral load results in some of these cohorts, that if you follow this target, then this is completely understandable. Then, of course, if you increase the dose, you become much higher, and with this BID dose, you are above also this target. And with the once daily 100 milligram, you're a little bit in between of these targets. So it's really about the targets that you believe that is important to make up a decision what you should do with the dose. So then I have some data also on pediatrics, on children, where we initially followed the same advice for the BID dosing regimen. Also, for the sake of time, I'm not going to go into all the details, but I can just conclude that we saw the same effect of the dose modification to twice a day, giving the same result as in adults. So the data for the children are really confirmed with the data from the adults. And I can already show you that next month at CROI, we also will show you the data for dolutegravir in the younger children under 1 year, which also look the same way. And then finally, one slide on this idea of the higher doses of rifampicin. So this is a study looking at 35 milligrams per kilogram versus the 10 milligram per kilogram, which is around the 600 milligram of rifampin. And when you look at the main pharmacokinetic outcome, you see that with the dolutegravir, which is given here twice a day, because that's the standard recommendation until today, with the normal dose of rifampin, you are with around the 1 milligram per liter concentration. If you give this higher dose of rifampin, you get a lower trough concentration of dolutegravir. So it suggests that with the higher doses of rifampin, you get even more enzyme induction and you get lower concentrations. So whether that's acceptable, again, is depending on the targets that you are following. So coming back to this list of remaining research questions, these 5 questions I shared with you, and I put here some of these answers. So for the discussion about patients versus healthy volunteers, you can say, okay, BID dosing gives you good concentrations, a little bit lower than was predicted from healthy volunteers, but clinically adequate. Whether you really need the BID dosing is really a matter of debate. It's dependent on whether you follow which target. And there's a very important, interesting study, the Radiant study from South Africa. It's a phase 2 study. That is a very interesting and challenging study where they decided to compare the unadjusted dose of 50 milligram once a day versus the recommended twice a day 50 milligram in patients with TB HIV, and then follow the patients. We've seen a presentation at the IES conference last year showing similar viral load responses, but we have to wait the full publication to really make a judgment on that. If you are concerned about adherence and you want to give it once daily 100 milligram, I'm not sure that's giving you a lot of benefit. And again, there's also depending on the targets that you follow, whether that is adequate, yes or no. The higher doses give more induction, so that's also now important to investigate in more detail. And we can say about the pediatric data that the results are similar as for adults. But you know, with any more research, you always get more questions. So I can also now come up with a number of new questions. So if this Radiant study that I just mentioned, if that really is demonstrating similar virological efficacy of the unadjusted dose of 50 milligrams, which could be similar as some of the cohort data that I showed you, will that result in a guideline change? So will be the official recommendation that you can stay with the 50 milligram once a day? I'm not sure whether that's going to happen. I can only say for now at the moment that if you are in a situation where you only have TLD available and you cannot give separate dolutegravir tablets, maybe just TLD is sufficient. It would be good to have some data on that, but that's a decision you can make depending on the results that you have now. I think for the high dose rifampicin data, because you have a stronger induction, I think at the moment it's better to stay with the BID dosing. I think for the children, we will also for the coming years stay with the BID dosing, but maybe if something is going to change in the adult population, maybe we can follow that also in children. And I did not discuss anything about pregnancy. We heard this also this morning. If you have a situation that you are going to give rifampin and dolutegravir, I think you also have to give BID in pregnancy until we have more data. So then the rest of my presentation with some of the other information. You know there's also bictegravir as another integrase inhibitor. It looks like a little bit like dolutegravir, but it is different. So there has been a healthy volunteer study that showed that if you increase the bictegravir dose to a BID 50 milligram, it's not sufficient. So that's really different from dolutegravir. But what is similar as with dolutegravir, that's this discussion about the targets. But also bictegravir has a very high Cmin versus IC95 ratio. And if you look back in this healthy volunteer study, all the subjects actually, although there was a strongly reduced bictegravir trough concentration, it all remained above this IC95. And the modeling study that was conducted showed that actually if you transfer that to patient situation, that maybe only around 3 out of 1,000 patients actually will have a trough concentration below this IC95 if you give the bictegravir twice a day. And now, based on this modeling exercise, the INSIGHT study has started that is evaluating bictegravir twice a day with rifampin. Well, initially we thought that was never a way to go, but now maybe we will get the results and this could be another combination. I'm also like to show to you some of the data that was collected here in Thailand with boosted lopinavir in rifampin. But that, I have to say, confirms a lot of the other data that had been collected so far, that really with the rifampin, reducing the lopinavir concentrations, that it's very difficult with dose adjustment to come into the therapeutic range for a sufficient number of patients. So I think we need that kind of data in the rare situation that you have to combine a boosted PI with rifampin, but I hope that we will have more patients on integrase inhibitors with rifampin and using all the information I just presented. So then a few slides on the TB prevention, rifampin. Rifampin is like rifampin, also an enzyme inducer, but less strong. So we call it a moderate enzyme inducer. So maybe not necessary to modify the dose of dolutegravir if you combine it to rifampin. This was a study that was done with the weekly rifampin. So for 3 months, the 3 HP regimen that was studied, they just gave the normal dose of dolutegravir. You again see this 1,000, and it's reduced a little bit, 50% or so, so not as strong as with the rifampin. And also all these subjects had suppressed viral load during the trial. So that's very clear for this 3 months rifampin combination, you can really stay with the normal dose of dolutegravir. We don't have any information yet about the daily rifampin, so the 1 HP recommendation. I will give you some more information on the next slide. And we don't have any data on children so far. That is being collected. You could expect, if you give the rifampin on a daily basis, that you get a stronger enzyme-inducing effect than with the weekly dosing. And then you come up with the same question, is once daily still sufficient of dolutegravir? But you can already imagine that is having the same discussion as I shared with you for the rifampin. It's really dependent on the target. And that will be studied both in an ACTG study in adults and also in children. And I think that it will be very interesting to follow the discussion on the rifampin dose modification, if that is being changed into no reason for dose modification. Then I think that it really is going to influence also how we look at these data with rifampin. Finally, the last slide, I believe, on rifampicin with a boosted darunavir. That's another combination that did not give very good results, both in terms of very low concentrations of darunavir, but also some significant hepatotoxicity in these patients. So it shows you that we really have to study all of these separate combinations to see what is the pharmacokinetic effect, but also what are the safety issues around these combinations. And this again shows you that the combination of a boosted PI with rifampin is not ideal. We should really focus on having the data on rifampin with the integrase inhibitors. So coming back to the case presentation, I told you this concentration. Now you can make the interpretation yourself. It should have been 1 milligrams per liter, so clearly reduced. Before we further changed the dolutegravir dose in this patient, we gave the recommendation that you can also take dolutegravir with food, that you get better absorption. And we repeated the TDM after 2 weeks, and now it was indeed much better. We also see sometimes patients improving in their health during the treatment, so that gives you also better food intake, better absorption of medications, and the viral load remained undetectable. So that was a relatively easy case where we only had to apply TDM and repeat it, and a good virological outcome. So the conclusions of the presentation, I talked a lot about dolutegravir and rifampin because I think it's a very important drug interaction with a lot of more information now collected over the last couple of years. There are still some remaining questions I shared with you. The rifampin, as far as we know now, weekly dose can be given with the normal dose of dolutegravir, and we really need further studies in relevant local or regional patient population. And with that, I thank you for your attention. Happy to take any questions.
Yes, it was a short case, but an extremely comprehensive overview of the
a good balance, yeah.
of the literature. Thank you. Does anybody have any questions?
So, hi David. So thank you very much for your excellent talk. So just would like to ask you about the 1 HP and TLD. So whether it can combine together, because as you said, you will wait from the data of A5372, right? But when we look at the data of A5372 that was presented at CROI, it seems like they have higher DTG concentration than from the dolphin trial. I mean, when look at the DTG only, and the difference is, so for the A5372, they have about 25% of Asian population compared to just, so for the dolphin, it's all South Africa. So can we extrapolate from that result that for the Asian or for the Thai people, maybe they don't need another 50 milligram, because for 1 HP it's quite short, it's just 1 month. And also with the data of TB patient, you said that, oh, maybe we can use it, TLD without 50 milligram additional. And also for TB it's longer duration than 1 HP. Can you comment on that?
Thank you, Angeli, for this very easy question. No, I can only say to you that if you look at this history, so the Kelly-Dooley paper, the phase 1 study was 2013, so that's 10 years ago. And at that time, everybody thought it was clear. So we know everything, it's clear. We just have to confirm it, and then we are there. You've seen how much changes in our thoughts, and also based on the data and different opinions that have arisen during these 10 years. So if you would have asked me this question 10 years ago, I say, no way, you cannot do it, even not in Asian patients with low body weight or whatever. Now, when you look at the data and you see some of these results, and I must say that over the last couple of years, I've become a stronger believer of the lower target than I used to be a few years ago, really recommending the higher target. I think that you may be able to, even with the 1 HP rifampin, to stay with a normal dose of dolutegravir above the 64 nanograms per ml. And then in addition, because you say in Asian lower body weight, it's only 1 month. So I think you have a lot of arguments to say, okay, this should work, this could work. And then the next question, and that's a question to you, do we need a study to confirm that? And I think that's also one of my recommendations in my concluding slides. I think we need studies from this region with patients from here, based on the current knowledge, and we do have a lot of knowledge. We have a hypothesis, like you expressed, and I'm very happy to participate in setting up this kind of studies. And I think now it's the time, and you have sufficient information to also convince ethical committees that you can do this. And so I think it should be possible to give it once daily with 1 HP, but I would like to see the data.
Okay, so thank you very much. So actually, we just completed the PK study, but the result of the PK is not yet available. So we will consult you later. So thank you very much.
You're welcome.